In this video, I will discuss the pharmacological actions, clinical indications, and adverse effects of heparin. Heparin is an anticoagulant medication that prevents formation of blood clots. Heparin works by indirectly inhibiting two clotting factors, thrombin and factor Xa, and by binding to and enhancing the activity of an anticoagulant protein, antithrombin 3. Let me explain a little about the coagulation cascade. Here is a quick overview. The coagulation cascade begins via two pathways, the extrinsic and intrinsic pathways. Each pathway has different clotting factors. The intrinsic pathway starts when circulating factor 12 comes into contact with the surface of activated platelets or collagen. This process activates factor 12, which in turn activates factor 11, which activates factor 9, which activates factor 10. In the extrinsic pathway, the exposed tissue factor activates factor 7, which activates factor 10. The intrinsic and extrinsic pathway meet at factor 10, which is the start of the common pathway. Factor 10A activates factor 2, or prothrombin. Factor 2A is also called thrombin. Thrombin activates factor 1 or fibrinogen to form fibrin. Fibrin is the end product of coagulation cascade. Fibrin mesh reinforces the blood clots, which is formed during primary hemostasis. Now, let's focus on thrombin. In addition to the cleavage of fibrinogen to fibrin, thrombin has other pro-coagulative functions. Thrombin activates two other clotting factors, factor 5 and factor 8. Factor 5A acts as a cofactor for factor 10A in common pathway, and factor 8A is a cofactor for factor 9A in the intrinsic pathway. These cofactors accelerate the speed of coagulation cascade. Thrombin proteolytically cleaves stabilizing factor or factor 13 into factor 13A. Factor 13A combines with a calcium ion cofactor to form cross links between the fibrin chains, further reinforcing the fibrin mesh. Moreover, thrombin can bind to receptors on platelets, causing them to activate. Activated platelets change their shape to form tentacle-like arms that allow them to stick to other platelets. On the other hand, the coagulation cascade is countered by several anticoagulant proteins. One of the anticoagulant proteins is called antithrombin 3. It is sometimes just called antithrombin, a protein made by the liver and released into the blood. When antithrombin binds to clotting factors, these factors do not have coagulation properties. Antithrombin can bind both thrombin and factor 10A, and thus inhibiting their coagulation activities. When thrombin binds to antithrombin, it cannot cleave fibrinogen to fibrin, it cannot activate factor 5, 8 and 13, and it cannot activate platelets. When factor 10A binds to thrombin, it cannot activate factor 2. Now, let me explain the mechanism of action of heparin. Heparin is a natural anticoagulant, and it prevents the formation of blood clot in our body. Heparin does not block the clotting factors directly. Instead, heparin binds to antithrombin 3, and markedly potentiate the anticoagulant activity of antithrombin. By increasing the anticoagulant action of antithrombin, it indirectly blocks the action of two clotting factors, factor 10A and thrombin, and thus inhibiting the coagulation cascade from factor 10A and downstream. The anticoagulant activity of heparin is related to the chemical structure. It has two parts. There is a chain made of 5 sugar molecules, called pentasaccharide body, and a tail which is made of glycosaminoglycans. Depending on the length of tail, there are two types of heparin. Heparin with longer glycosaminoglycan tail is called high molecular weight heparin, whereas low molecular weight heparin has a smaller size, they have a much shorter tail. Both high and low molecular weight heparins combine to antithrombin 3 via the pentapeptide body. This pentapeptide body enhances the antithrombin to inhibit factor Xa. However, inhibition of thrombin requires long glycosaminoglycan tail. Only high molecular weight heparin has an inhibitory effect on thrombin. Heparin is available as either unfractionated or fractionated. Unfractionated heparin refers to heparin which is derived physiologically, usually from pig intestine, and is a mixture of both high molecular weight heparins and low molecular weight heparins. Fractionated heparin is created when unfractionated heparin undergoes a process where the tail of high molecular weight heparin is partially chopped off. So fractionated heparin consists of only low molecular weight heparin. Enoxaparin and dalteparin are commonly used low molecular weight heparin. They have better bioavailability and have a 2 to 4 times longer half-life compared to unfractionated heparin. There is another drug, called fondaparinux. It is a synthetic molecule, which contains only pentasaccharide chain. It has no glycosaminoglycan tail. Fondaparinux has pharmacological action similar to that of low molecular weight heparin. It indirectly inhibits factor Xa, but has no effect on thrombin at all. Half-life of fondaparinux is longer than low molecular weight heparin. Low molecular weight heparin and fondaparinux are excreted by the kidney, so dosage adjustment is necessary in patients with renal function impairment, and they should not be used in patients with eGFR lower than 30 ml per minute. Unfractionated heparin is metabolized and cleared by the reticuloendothelial system, and can be used in patients with renal impairment. Heparin is administered intravenously or subcutaneously to patients who need short-term anticoagulation and immediate anticoagulation. It can stop or prevent blood clot formation usually within seconds, as it has rapid onset. Heparin is used for many acute problems. It is the medication of choice during an acute deep vein thrombosis, or preventing postoperative deep vein thrombosis and pulmonary embolism. In patients with atrial fibrillation that has persisted for more than 48 hours, heparin can be used to reduce the risk of thrombus formation and embolization, until the warfarin level is therapeutic or cardioversion is performed. For chronic management, warfarin or direct oral anticoagulants are usually preferred, since they can be taken per-orally and the patient can take the medication at home. Heparin is also used as adjunct therapy in acute coronary syndrome, and during procedures such as cardiac catheterization. Heparin is the preferred anticoagulant in pregnancy, because, unlike other anticoagulants like warfarin, it does not cross the placenta and it does not have any teratogenic effects. The major side effect of heparin when administered therapeutically is bleeding. We can monitor the anticoagulant effect to maintain levels in the target therapeutic range. The most widely used laboratory assay for monitoring unfractionated heparin therapy is the activated partial thromboplastin time, or APTT, which evaluate all clotting factors of the intrinsic and common pathways of the coagulation cascade. Normal APTT is between 30 seconds and 40 seconds. When a person is on unfractionated heparin, APTT is approximately 50 to 90 seconds, or 1.5 to 2.5 times the baseline value. If a person was given too much heparin, then the APTT can rise to values greater than 100 seconds, and there is a high risk of internal bleeding. In such situation, protamine sulfate can effectively reverse the effect of heparin. It is partially effective on low molecular weight heparin, but no effect on fondaparinux. Low molecular weight heparin does not require monitoring, and APTT is also irrelevant to low molecular weight heparin, as it has little effect on thrombin. We can do factor Xa assay if we want to know the efficacy of low molecular weight heparin, fondaparinux as well as unfractionated heparin. Another notable side effect of heparin is heparin-induced thrombocytopenia. This immune-mediated process is more commonly seen with unfractionated heparin. It can bind to a protein that is present on the surface of platelets, called platelet factor IV. This heparin platelet factor IV complex is antigenic. It can stimulate the immune system to produce antibodies. These antibodies label the platelets to be destroyed by the macrophages in the spleen. This results in low platelet count, and hence called heparin-induced thrombocytopenia. A serious complication of heparin-induced thrombocytopenia is called heparin-induced thrombocytopenia with thrombosis. In this scenario, the antibodies bind the heparin platelet factor IV complex, causing platelet activation and platelet aggregation, paradoxical thrombosis, which may present with serious thromboembolic complications. Heparin-induced thrombocytopenia occurs in 5 to 10% of patients treated with unfractionated heparin, and the risk is lower with low molecular weight heparin. Since it is an antibody-mediated process, it takes 5 to 10 days to produce antibodies in clinical presentations. However, in patients who has been exposed to heparin in previous 1 to 3 months, the antibodies that target heparin platelet factor IV can be already formed in the blood. In such patients, heparin-induced thrombocytopenia can develop within the first 24 hours. If heparin-induced thrombocytopenia occurs, the heparin is stopped and switched to a different anticoagulant, like direct thrombin inhibitors, such as dabigatran, argatroban, or bivalirudin. Other notable side effect associated with heparin is an increased risk of osteoporosis. Heparin has interaction with other medications. Some medications like aspirin, ibuprofen, and warfarin can enhance anticoagulation. Heparin has been known to have decreased anticoagulation effect with medications like digitalis, tetracyclines, antihistamines and nicotine. If you learned something new from this video, make sure to subscribe to our YouTube channel. If there is any suggestion, please let me know by leaving a comment below right now. Thank you for watching this video. Stay safe and healthy.